right, guys, part 3 here. Let me make myself big here. There we go. And part 3 has to do with the special situations when we're dealing with newborns, okay? This is what I kind of call the trivia part of it. But again, it's kind of important. Meconium. Again, Velcro for the baby's lungs is their first poop. Usually caused by intrauterine stress. Okay? Usually it can cause hypoxia, and it's usually a dark green substance that in the digestive tract of a fully termed newborn. Again, they get a little bit stressed. They take a poop inside mom, and it gets in the amniotic fluid, kind of creates all kinds of havoc and chaos. Again, there's 2 versions of it. There's the thick meconium and the thin meconium. Thin meconium usually is already in there. It's not as bad. The thick stuff is what we're kind of worried about, okay? And so non-vigorous infants born with thick particulate meconium should be immediately intubated. Do not stimulate these kids. Don't let them take that first breath. Get that crap out, literally. Okay, again, if they, you can have a complete airway obstruction because of the thick meconium, all right? And again, the little balls can get into smaller airways, and that prevents exhalation. It can become a real mess. So the more of it that we can get out. Here's the problem: is once they take that breath in, it kind of dooms them to. And they're going to have a lung lavage. They're going to have to wash it out, and that's going to have to, of course, be done at the hospital. Hopefully, that doesn't happen to you. So again, you're going to continue. Now, remember when I said they only give you guys 1 tube? So this is the dumbest thing that agency could freaking do, especially in sizes 2.5, 3, 3.5. So the way I kind of overcome this is I will use the 2.5 tube. Guys, when you're doing suctioning, by the way, the smaller the tube, the less you can get out, okay? So usually this is going to clog your tube up. So what I do is I put a bottle of saline out there, and I suction it out. I'll clean it out real quick. I will go back in, suction it out again, and then after I've got everything cleared out, then I'm going to take that brand new fresh tube that's fresh out of the package and then put that one in, okay? So that's my little workaround for that. But again, agencies that don't let you carry more, again, you can sit there and suction them, and again, the smaller tube, use a smaller tube than what you're expecting to use, okay? If you got a neonate, here's the good news, a premature neo, most of the time they don't have meconium staining because they don't have meconium yet. So actually you kind of got, it's a little bit of an advantage, okay? Again, warm the infant to prevent hypothermia, and then rapid transport where they can actually handle the kid, okay? Do not take them to the closest ER. It's probably a bad move on your part, because then, remember, if you take them to that closest ER, they have to call in the specialized mobile unit for the neos. That can take in some places 2 to 3 hours, okay? Especially when you can spend the extra 15, 20, 30 minutes taking them to an appropriate facility. Really, it's better for the baby that you're doing that. Again, this is a completely situational thing. If you don't think you can handle it, then you need to take them to the closest facility that can handle the problem. If they have apnea, kind of got to figure out why they're having apnea. Most of the time, I can pretty much tell you is from maternal depressant use. They could be septic. They could have a central nervous system disorder. All these things can cause them to have apnea. Again, try the tactile simulation first. Bag them, ventilate them. Do not wait till we get to the ambulance to do it. You need to start bagging them then and there. Take your stuff to the patient, okay? And if the infant still doesn't breathe on their own, again, perform direct tracheal intubation. Remember, Dr. Frank kind of frowns on that. Put in an OPA, bag them, okay? The only time I would say to actually intubate is, again, only if you got meconium staining or there's some really freakish reason that you would, this might be one of those freakish reasons, where you've got a diaphragmatic hernia, where basically all the gastric contents are up in where the lungs are supposed to be. They're going to be cyanotic and having trouble breathing despite ventilations, okay? And then you're going to hear bowel sounds in the chest, and the heart sounds are going to be displaced to the right. Again, really bad thing. Again, place the infant with the head or thorax higher than the feet. Basically lift them up, okay? Put an NG tube down, put it on low intermittent suctioning, and use the BVM, and again, usually requires a surgical repair. So this is how we're going to actually transport. And this would be another one that I would probably go ahead and intubate, just because I want to make sure that I've got a clear path to the lungs to where I'm not inflating, putting air in here that's then going to cause additional increased intrathoracic pressure. Bradycardia in a neonate. It's usually hypoxia until proven otherwise. Okay? Follow the pyramid. Follow that inverted pyramid. Keep them warm. If they still don't respond, epinephrine 0.01 milligrams per kilogram. Give them a push dose. See what happens. Okay? But again, bagging cures 99.9% of bradycardia problems. All right? So they are considered premature if they are 37 weeks, or if they're somewhere between 6 to 2.2 kilos. They will be considered usually fetal, actually 23 to 24 weeks. Shan's actually had one not too long ago. They delivered at 22 weeks, and they were able to, the baby was discharged from the hospital with no serious side effects. So they're doing great things all the time. So guys, the fetal viability is still very much up there. I can tell you 23, 24 weeks and being born in the field, they're really behind the 8 ball. Okay. I had one at 28 weeks that was born, and she did survive, but literally that was, I would have to say, one of my top 5 crazy calls. So again, prematurity, usually their respiratory tract just isn't developed. Okay. They've got different vital signs. They're prone to intraventricular hemorrhages. Their serum osmolality changes. Basically, it messes with their blood chemistries. Okay, and they're very susceptible. Their skin is so very paper thin. Okay, they lose body heat very easily. Usually they're in an isolate for weeks and weeks and weeks on end, maintaining the. And they have very large body surface area, but a really small birth weights on these guys. Okay. And they don't have any fat stores, okay? They don't have any insulation, all right? They can't shiver, so they can't maintain their heat that way. So heat control, especially on premature kids, is very important. Their heads are usually really big, and of course, they lose a lot of heat through there, so make sure. This would be an example of a premature newborn. Notice they've already got this baby intubated. This one doesn't look too bad, though. This is like the 33, 34 weeker. Not too bad. All right. So again, if there's any time that you think that there's a chance of life, guys, work it. Go ahead and work it. Do that. The medical direction may advise the administration of epinephrine to keep the heart rate up. Remember, guys, this is how they keep their blood pressure up, is to keep the heart rate up. Bag them. Make sure they're doing good. Make sure you're oxygenating them well, 95%. And then, again, maintain your body heat. Epinephrine to keep the heart rate up, and transport is necessary. Okay? Again, respiratory distress or cyanosis is probably a lot more common than you think, and it's usually because their respiratory control center is it's still learning. Okay, so it affects the environment and metabolism changes. They get affected super easy. Okay, again, they can also have any of these contributing factors. So again, if they're having these, again, make sure that they're oxygenating and ventilating well. A tachycardic kid, I would probably say, is more likely hypoxic. It's an early stage of hypoxia. They have paradoxical breathing. They're grunting. So again, follow the inverted pyramid for treatment of these guys. Hypovolemia, and it's usually because you let something bleed that you shouldn't have. Okay. They usually 99% of the time they don't have this, but they can. Okay, they can third space fluid. And dehydration is kind of a common cause. They'll have a pale skin or a cool skin, and they'll have diminished urination, and they'll have dark urine in the diaper. Okay, so again, if they're not babies they'll usually pee on you that first couple minutes. So if they're not peeing on you, you need to be thinking, oh, why are they not peeing on you? Okay, want to make sure to avoid solutions that use dextrose here. Okay, and the reason that I say that is that, again, sugar in those little veins, it can worsen things, and it can cause ischemic brain injury. So 1/2 or normal saline is usually half normal saline or normal saline is what we're going to use. Seizures usually indicate some other serious abnormality, okay? And again, we got to stop the seizure along the shore. Their seizures, though, are kind of different. They do a chewing motion, or they blink. They start sucking abnormally. The increased salivation, changes in colors, okay? They may have a tonic where they get rigid in the trunk or the extremities, and then or muscle twitching groups can happen. Myoclonal is a brief jerks. And when you're seeing these, by the way, most of the time it's because of low sugar, usually. But they can be septic or have a fever. They can have drug withdrawals from this. And again, decreased level of consciousness and seizure activities are kind of go hand in hand. All right, so how we do it, make sure they're oxygenated and ventilated. I'm going to stress that one again. Make sure they're oxygenated and ventilated. Anticonvulsant, I would probably confirm on a neonate what they would want to do. Remember that benzos are kind of, they can order them, but I would definitely consult with the ER doc and say, hey, I need to kind of know what to do on this one. Okay? Fever, again, if anything greater than 38 rectal, or again 37.5, again, it's probably a pneumonia or a sepsis. And again, follow the inverted triangle on these guys. Maintain their bodies. Remember that the baby has a hard time containing their own body temperature. Okay, so and they develop rashes or petechiae very quickly, very easily. Okay. So again, ensure that the patient's airway is adequate, but again, don't use cold packs on these guys. Don't use air conditioning. Let the fever go till they get to the hospital, okay? So again, if they get bradycardic on you, usually it's because of hypoxia. Make sure they're ventilated. You have to provide chest compressions if they get below 60. And again, explain the need for transport to the caregivers. They absolutely need to go to the hospital. All right? So again, hypothermia, get them warm. The simple way. Dry them off, get them warm. Babies don't shiver. The newborns don't shiver. They're going to be, if they're cool to the touch, they're too cold, they need to be warmed up. They're going to start turning a little blue, especially in the hands and feet. They can go bradycardic on you. They can start having initial irritability, and then they're going to have lethargy in the later stages of it. All right, so warm them up, warm them up, warm them up. If they start, the heart rate gets below 60, again, chest compressions are indicated. Don't microwave your fluids, guys. The last thing we want to do is boil these guys. And the newborn must be kept warm. Keep them warm, keep them warm, keep them warm, okay? So remember, the more premature that they are, the more chance that they have of having low sugar, okay? Little neos and little infants don't have the sugar stores. So make sure that they got an adequate glucose. If you're going to do, by the way, a glucose on these guys, do a heel stick. Heel sticks are what we do for those little guys, okay? Yes, they're not calloused up yet. You can easily get a blood sample from their little tootsies, okay? So a sugar below 60, again, would be something to treat. Less than 45, this is what they say for the... again, definitely below 45 is an absolute treat. I'd say below 60, small doses. When I say small doses, if you've got D5 or D10, those are the ones you want to give. And again, make sure that you know how to make your D10. Weaken it out. Guys, the higher the concentration of sugar, the more caustic it is to their little veins. Okay? We do not give it IM. We don't give them glucagon. Glucagon burns up the fat stores. Oh, yeah, they don't have fat stores. Okay? So, again, they're going to have like seizure-like activity. They're going to have the apnea. They're going to have irregular respirations, probably a little cyanosis. And these are all signs of sugar. There is no way I'm giving them D25. D10, I would even weaken it out to D5. Okay? There's no way you give them D25, guys. D10, if you don't know how to make D10, again, take a flush, push out 2 mLs, grab 2 milliliters of D50. You now have 10 milliliters of D10. There's only 1 gram in there, okay? So give them a gram. Again, usually it's 0.5 grams, but again, these are neonates. If you got a 3-gram neonate, again, all right, we might have to do 2 flushes. Okay, it's not a big deal to do it that way. If they're vomiting, again, make sure that there's no dark blood signals, life-threatening illness. Again, vomiting of mucus is not uncommon. They spit up all the time, okay? It can be a symptom of a more serious disorder, though. Again, needs to be investigated. Make sure that they don't have a distended stomach or signs of infection. If they're going through drug withdrawal, again, they can throw up, all right? So, and again, and the problem is they don't take in the fluids that way, and because of that, they can become dehydrated, okay? So they should have 5 to 6 stools per day. That's kind of normal, especially when a breastfed infant. They can have that. If they're going more than that, again, they start losing fluid, and therefore they get dehydrated, okay? If they've got an infection, any type of gastroenteritis, they have any type of these, or cystic fibrosis kid has a lot more diarrhea than most other, because again, the little fibers in there kind of interfere with the gastrointestinal tract. All right. Again, just make sure that if you got loose stools, they check their urine output. How many times have they been peeing? Again, if they got a prolonged capillary refill time, this usually means a sign of dehydration. Okay. And again, your fluid therapy for these kids, 10 mLs per kilo. Okay. That's not much for a 3-kilo kid. 3 flushes. Okay. Usually when I'm giving fluid boluses, I use a flush on these guys, okay? However many flushes that I need to use, all right? Very rarely do you use more than 10 cc's and then see what happens, okay? Birth injuries. The biggest ones that you get with these is probably your shoulder dystocia. And this is where they separate the shoulder while they're trying to get out of the vagina. And again, breech presentations can cause some other issues with that. If you got a diabetic mom, you more than likely have a really big kid, bigger than the vagina can hold. And so again, these are some common problems that they deal with birth injuries, okay? There can be paralysis lower than the spinal cord, especially if you are trying to grab to pull the kid out, which is a big no-no. They can have diaphragmatic paralysis from coming out through a space that it's way too small for them. So again, they can have movement on one side of the face when they're crying, inability to freely move their arms at the clavicle site. That's usually the sign that they've separated their shoulder. And usually guys just put their shoulder in and hold it in place there. They usually will heal up on their own, okay? Make sure that they protect their airway. Inverted triangle is the same as before. And let them know about administering medications or non-pharmacological steps that you can do to decrease the problems with the birth injury. Okay? We've talked about this already with that. Make sure, guys, assume that if they come out not breathing, that it's intrauterine asphyxia. If they come out bradycardic, start your resuscitation. They should be bagged. They're below 60, start compressions. Ask the mother about any type of illegal or even legal substance use. You need to find out if they've been taking any type of narcotics. Okay. Again, you can have congenital problems that can also cause major issues there. We've already talked about all these guys, so we're not going to deal in it. Just remember, and I guess you're going to see primary and secondary apnea, guys, or you're going to see it. Okay. So understand the difference between a primary and a secondary apnea, okay? They usually stop breathing, they'll gasp a little bit. Secondary apnea, they quit breathing altogether, okay? Assume that it's that they quit all breathing altogether because we don't have a intrauterine monitor. All right, again, follow that inverted triangle for that, okay? So remember, guys, with neonates, 0 to 28 days, really important about that, okay? And make sure that protect their airways, support their ventilations. 99% of all your woes will go away if you can do those two things. Okay? Very rarely do you have to go to drugs. The only drugs you're probably going to need for these guys is epinephrine and a really tiny syringe and maybe a little bit of Narcan after you talk to the doctor. Okay? And if they have a distressed newborn, again, immediately ventilate, stimulate, and if required, do CPR on those. Don't wait. Please don't wait. Don't wait. Don't wait. Okay? Titrate your oxygen to the effect where you can get oxygenation for the patient. All right, that's it, guys. I know a long chapter, but we will see you on the next one.